On behalf of the Center of Regulatory Excellence at the Duke-NUS Medical School in Singapore, I'd like to welcome you to today's webinar. And the topic is opportunities for capacity building and training for patient groups in patient engagement and involvement. I would just like to make a few opening remarks before I pass over to the session chairperson. The question we need to ask ourselves is, why do we need to engage patients in all that we do in the healthcare system? And some of the points that you see on this slide summarize the key initiatives and imperatives, because patients are the ones who live every day with health conditions, so they're able to express what are the greatest problems and benefits of any therapies or medicines or treatment that they receive, and they are able to assess what they value most. So because of that, patients, and we are all patients at some point in our lives, need to be involved early in new medicines and medical device development prompted by unmet medical needs, because there is a clear gap between what is available, but also what is desired for prevention, diagnosis, and treatment of medical conditions. And patient inputs are critical. They can inform the development, the regulation, the use of medicines, including all these aspects in the development cycle and use of medicines and life cycle of medicines that you see on the screen, whether it's clinical trials, all the way down to assessing patient information materials, monitoring medicine efficacy, and also issues related to adverse events. The Center of Regulatory Excellence, or CORE, has been involved in patient engagement initiatives for several years. We held regional roundtables in 2019, 2020, and 2021, even during the pandemic. And during this period, we launched the Coalition to Accelerate Patient Engagement, or CAPE, in the Asia Pacific. And the purpose of CAPE is to advance systematic and meaningful patient involvement in health systems across the region. So what you see on the slide here is a summary of the key events and initiatives that have been going on leading up to our scientific conference in October 2022, when we looked at the theme of patients as partners for health, co-creating equitable access to health products and services. We are now looking, as we go through this webinar, to what happens this year in 2023 and in the years ahead as we build on the initiatives to date. During the conference, there were three major themes, and they were summarized in a conference statement that you can find on our website. The first is really to encourage and support the sharing of best practices in patient engagement from the Asia Pacific, but also looking globally at what is done to increase patient involvement in the development, regulation, and access to health products. We also encourage stakeholders to take active steps to increase the level and quality of patient engagement and partnership to ensure equitable access to health products and services in and across the Asia Pacific. And thirdly, we call on stakeholders to support efforts towards meaningful collaborations through multi-stakeholder platforms that will facilitate regional capacity building in patient engagement. The training of stakeholders covers many aspects. One key area would be the training and education of those who engage patients. And this would involve knowledge, skills, expertise, but also understanding the value of patient involvement. This would involve tools and metrics and how to use them, and also the important aspect of how to communicate across the different stakeholder groups and with policymakers, governments, and regional leaders. And then in terms of patients themselves, there is a need for training and education to help patients engage in medicines development and health technology assessment, and also the similar issues of communication and negotiation skills using real-world case studies and databases on patient perspectives. But what is fundamental is that while patient engagement has been rather well developed in the US and Europe, in other parts of the world like Australia and New Zealand, in most of the Asia Pacific, there is still a need for patient engagement training that is tailored to the region, because the region is extremely diverse in its social, cultural, and health systems. And so there needs to be adaptation and customization. And so as we look at this year and the next 2 years, we've identified capacity building as a key area to address in the Asia Pacific. There is a need for programs and training that are targeted, that are relevant, that are applicable to the Asia Pacific. And so the Coalition to Accelerate Patient Engagement will draw on the Center of Regulatory Excellence's expertise and experience for capacity building and training. And our key audience are patients and patient groups, but very important are the partners in all this, the industry, the regulators, the policymakers, and they will all form part of our capacity building initiatives. So in summary, as we look across the region, patient engagement is relatively nascent, but it is at a very important inflection point where stakeholders should commit to resolving all the barriers that exist, whether they're institutional, attitudinal, social, or professional. And we also note there are many opportunities and interested stakeholders across the region to advance patient engagement. So CORE offers a neutral academic platform within the setting of the Duke-NUS Medical School in Singapore for local and regional stakeholders to collaborate and to share best practices, and importantly, to build capacity by training relevant stakeholders in patient engagement. The ultimate aim of all of us, not just within CAPE or CORE, is to create an ecosystem that will increase the level and the quality of patient engagement to ensure equitable access to health products and services. So on that note, I trust that you will have a very enjoyable and informative webinar today. And at this point, I would like to pass the time over to Rajrajan, who will be chairing the panel discussion. Thank you very much.
Thank you, John. I'm going to start by sharing a deck of slides. So let me start by welcoming all of you to this webinar today. Besides myself, we've got a couple of our colleagues who have also attended the conference. But just taking a lead from what John has mentioned, I think I would like to go back to the 3 key points that we've actually, we have understood from the conference that we had in 2022. And I think today's meeting, what we're trying to do is to make sure that we can build on it, we can take it forward, and we want to make sure that we come together as stakeholders to actually develop further on it. So I think the first part will be the best practices and to increase patient involvement. The second would be the active steps to increase the level and quality of patient engagement with equitable access. The third would be meaningful collaborations through multi-stakeholder platforms. So my first slide speaks about stakeholders in the ecosystem. And I think when we want to talk about patient involvement and engagement, it involves a huge community that would include patient support organizations, pharma, industry partners, healthcare planners, policymakers, physicians, and allied healthcare as well. That seems to be the huge ecosystem that we must live in. And what we must realize is patient involvement and engagement starts at the very onset when a patient sees the doctor. It does not start, halfway through somewhere through the treatment process. It does not start where, we are trying to create something today. It doesn't start where HTA is involved. So I think what we need to think about is how do we become a community that involves patients and gives them that centricity that people have been talking about. I think in the last 2 to 3 years, 5 years maybe, it has been repeatedly said that organizations are practicing patient centricity, even hospitals for that matter. So I think what we need to do is to define what that centricity is, because I think when you look at it, the whole society can actually play a role in trying to figure out and to implement their involvement and their engagement. So when we look at patient engagement and involvement, I think one of the key things that we're looking at is the focus beyond clinical care. Because at this point of time, when we look at a patient, we all think about clinical care. And what we do is, we just forget about the dimensions of the patient's needs, the social, financial, information, and emotional support that actually they need. Those things included with clinical care actually provide a 360 degree support system for each individual patient as well. So if you look at the slides that we've prepared here, we call it the rudiments of involvement. We just hope that we can go back to the basics. We can figure out the start of all of this, and we can try and prepare at a national level on how we can move forward together as one team. So when we look at the patient involvement and also engagement, They start all the way from, literacy to improve disease awareness, encourage appropriate use of healthcare resources, effective consultation through dialogue, facilitate better doctor-patient conversations, conversation guides, explain investigation and diagnosis in the decision-making process, shared treatment decision-making together with the physicians, explaining treatment options, discussing with patients risks and benefits, patients make informed choices for their care, and of course, at the treatment stage is to ensure adherence to treatment, minimizing barriers to care, improving connectivity of support services to patients, harnessing technology, telemedicine. As for the continuum of care is to instill confidence and ownership. So when we talk about all of these things, we move on to the next level, which is the tiers of patient engagement. I think there are many levels, and if you look at this pyramid, it starts right from direct patient care, where I think the first immediate engagement point or involvement would be the diagnosis information to be shared with the patient, be it at the GP, be it at a specialist or at a hospital, and discussing the patient's preference in treatment plans. The next would be the treatment based on patient's preference, medical evidence, and clinical judgment. Explaining, discussing, and also educating the patient would then prepare them to be appropriately, enhanced with the skills to be involved as well. The next would be the hospital structure and governance to actually get their involvement and to actually figure out how best to actually engage with them. I think the hospital or the whole structure could actually carry out a survey on patient experience, use patients as advisors or care experts at hospital level. I'm glad to see that this is happening at many levels at this point of time. Hospital safety and quality improvement co-led by patients. So it is not a system-driven thing, but there's a patient involvement, a very strong sense of patient ownership as well. At the policy-making level, ministry conducts focus group discussions with patients on healthcare issues. Patient recommendations and research priority used in funding decisions. And the last would be patients represented at ministry panel on how healthcare programs can be resourced. In today's meeting, we're going to focus on Singapore, and many of these slides here is created on what Singapore is going through at this point of time. But we are looking beyond Singapore at this point of time with Kate's work. We're looking at Singapore, Malaysia, Indonesia, Thailand, and Philippines. But we are going to take Singapore as a pilot to actually move this forward. With that, I'd like to welcome my colleagues who's going to be on the panel today, and I'd like to call upon one by one. So we have Ms. Fiona Pierce, Senior Advisor, HD and Consumer Engagement and Education, Agency for Care Effectiveness. I'd like to call on Mr. Ekawat, National Haemophilia Foundation of Thailand and the Thai Rare Disease Foundation. I'd like to call on Prof. Tai Siong, Chief Medical Officer, Precision Health Research, and Neil Thomas, Patient Advocacy, Senior Director, Patient Advocacy from Pfizer. Hi.
Hi, Raj.
Hi, Raj.
Can you hear me clearly? Yeah.
Yeah.
Yeah. So I think I'm going to start by just going to Ekawat, being a patient himself and working out of Singapore. So Ekawat, I just want to ask you one question. How important is patient involvement and engagement? I think in the couple of slides that I shared earlier, we looked through the whole continuum of care. We looked from start to the end. We looked at the gaps as well. So I wanted to hear your thoughts before we actually start to base this discussion.
Yeah, I think it's very clear that when the patient engagement, they have different perspectives. For patients who start to have a group, so they may have like a peer-to-peer, they help each other to support each other. So they will benefit to the individual families. But when they get together and they can feel that they can involve in more, they can involve with the doctors and they can involve with the government representatives, that they might go up to the level that they might think about, okay, they can have asking for some beneficials from the government, and that a little bit bigger from what they start. But like you said in your slide, they have a tiers of the patient engagement. So we need to groom them up. It's not just start the patient group and we expect them to join in the HTA level or the policymaker level. So we had to starting with some simple things, grooming them, and then when they get ready, so they can put them into the upper level.
Thank you, Ekawat. Fiona, you've been working in Singapore, and just to set the foundation, I think if you could explain a little bit more about HTA and your work with ACE in Singapore.
Thanks, Raj. Yes, so ACE is the National HTA Agency for Singapore. We were established mid-2015, but formal work started in 2016. And we originally started work on assessing drugs and then medical technologies and more recently vaccines and some other types of technologies to inform funding decisions that are made by the Ministry of Health's advisory committees. So this is whether something is going to be subsidised by the government or put onto MediShield Life for claims. So it's a very comprehensive process, and the methodology that ACE uses is consistent with best practice in many other large HTA agencies globally, and we put it together based on experiences that we had from other markets, but also from working closely with those other countries that had best practices. Now, one thing that was lacking in the first years was involving patients in our processes, and this was done intentionally because there was a very limited understanding and knowledge of HTA from payers and also from clinicians who are other key stakeholders in our process. So we spent the first few years building up our processes and building up capacity of those stakeholders. Now that we're at a point about 7 years on where we feel that they're well equipped and they're quite familiar now with our processes, we recently embarked last year on establishing the consumer engagement and education workstream within ACE, which is specifically designed to support patient involvement in ACE's work. So this is not only helping provide that patient perspective or the lived experiences to inform an HTA, but it's also to help improve health literacy and co-design different resources and educational materials that patients and patient organisations feel that they need to be able to make informed and shared decisions about their treatment options with their clinicians and about their healthcare experience. So we're a relatively small team, but in January this year, we published a methods and process guide for patient involvement. It's only a short document, but it essentially sets the framework that we follow when we are engaging patients and inviting them to participate in our work. We also have some fact sheets as well, which provide visual aids and tools that are a much more digestible format as well for patients so that they can understand the key aspects of processes that they might like to get involved in and what's required of them. So it's been a long work in progress, but we're very fortunate that we've got very dedicated and passionate patient organisations here in Singapore who wanted to be part of this work, and everything that we have developed has been co-designed with them. And this has actually been, I believe, a kind of a change in the way that ministry often engages stakeholders, typically government, and this is not unique to Singapore. This is globally, a lot of governments tend to come up with drafts or almost finalised concepts, and then they get final inputs at the end to refine before they're published. We made a cognizant decision to really engage patient organisations early on and to co-develop all of our processes from the beginning so that whatever we create is relevant to them and meets their needs. And it's always going to be an iterative process. We're constantly evolving our processes as their needs change.
Thank you, Fiona. Prof. Tai, can I call on you to actually explain what PRECISE is about and why and how PRECISE can be part of this whole initiative that we're talking about with the banner of patient involvement and engagement?
Raj, I'm going to take a step back for a moment and not talk about PRECISE, even though that's what you asked me to do. So I'll give you a little bit of history, and I'm really glad to the way you sort of started this, because you've outlined for us a sort of many levels of patient involvement, and Fiona, you've spoken really at the sort of policy and decisions regarding how do we ration, right, essentially scarce resources. I came into this journey about 7 years ago now, when I was asked to set up something called the Center of Excellence for Chronic Disease Prevention and Management. And then the Dean of Medicine sort of asked me to he asked me, go find a problem. And we would use diabetes as an example, but go find a problem that you're willing to solve that would make a difference to how we think about patients living with chronic disease. And what I realized, I think, very rapidly as we sort of came into this, is that we very often talk about evidence-based care that is based on clinical trials. We also talk about value-based care, right, which is actually value very often seen from the sort of health system perspective, so the systems level practice. And don't get me wrong, I'm not saying that none of this is important, but it does sort of focus on one or two things around what it's like to live with the disease. And I think you alluded to this, and Ikawat, you've alluded to this too when you talk about sort of patient support groups and the needs of patients. And that is that for health systems, sometimes the easier route is to focus on things that are biological, but to ignore the psychological and the social aspects of disease and the impact on the patient's lives. For a couple of reasons. I mean, first of all, it's actually easier. Sometimes in the clinic, when I sit in the clinic, you don't want to ask the difficult questions, because if you ask them, then they're stuck, and then there's a long waiting line outside, and you know sometimes you're almost afraid to ask, and right. The other thing, of course, is that I may not have the skills. To sort of to extract that information in a useful manner and reflect it and provide support for the patient in a way that's meaningful to them. So we did come up with this sort of concept of patient-centered communication or patient-centered care. And Raj, as you said, many health systems are implementing it, but they don't always mean the same thing. And so one of the things that we feel is really important to articulate is what exactly is patient-centeredness. Because sometimes when we talk about patient-centered care, we talk about geography, right? It's having one place where the patient can receive all their care. Sometimes we think about it as looking at all different aspects of the patient, you know, all the different organs, so you don't split them up into individual organ systems. And actually, more often than not, when people talk about patient-centered care, what they mean is that they put the patient at the center of their PowerPoint presentation. That's not patient-centered care, right? In my mind, and the way we've defined it in the Center of Excellence for Chronic Disease Prevention and Management, is that patient-centered care is care that respects the autonomy of the patient, but actually is provided in the context of the patient's aspirations and needs, so that it makes sense in the context of their lives. And that's why we use terms like patients living with diabetes, and we don't talk about diabetics, for example, because the disease should never define the person. So I think it's important that even when I talk about PRECISE, that's baggage that I carried with me to PRECISE. And once I came to PRECISE, what it meant was that same set of values is brought into everything that we do. And so PRECISE has this goal of actually bringing genetic technologies or genomic technologies and integrating it into the healthcare system to improve the lives of our patients. And what we realize is that if you're going to do that, you need to pay attention not just to the biological, but also to the psychological and the social aspects of how these diseases and these tests and technologies impact on a patient. If you don't do this, what happens when you take a patient with a chronic disease and you only talk about the biological? It's not a question of how do we empower patients or how do we engage patients. In fact, patients are engaged the day they walk into my clinic. And by focusing only on the biological and ignoring the things that are important to them, we actively disengage patients. In fact, we've shown in our own studies that if you follow patients up with diabetes, over time, the level of activation actually goes down the more time they spend in the health system. So we think about this at three different levels. I think that we think about, and I'll sort of stop it as soon as I finish this last statement, but we talk about the paradigm. That's the culture. As a system, we need to believe that patient involvement is important. The patient voice actually should shape what we do. It doesn't mean that the evidence is not important. It doesn't mean that cost is not important. It just means that the patient's voice needs to be there as an equal, and the patient is an equal partner in all this. So that's the paradigm. We also realize that there need to be skills, and it's not just skills for the patient, but also skills for the providers or the policy owners, because the way we communicate, the words that we choose, very often actually inhibit patient involvement and patient engagement. And we need to be very careful about being able to use language that is open to reaffirm, to affirm and acknowledge patients' views, and actually act in a way that is consistent with those values and needs. And then finally, we need to have platforms. And I think that this is the biggest challenge, right? Even if you have a bunch of people who are committed to doing this, if you operate in a system where the values, the performance management, and the incentives are not aligned, all this will fail. And it's much easier for us to revert back to the traditional way, which is, Neil, this is not meant as a criticism of the farm way, which is actually, from the medical perspective, it's much easier just to write a prescription and actually not worry about whether the patient is actually taking the drug or not. So I think that's where I come from. It's a culture that I brought to Precise. It's not embedded as part of every precision medicine program, but this is how Precise has decided to go about the clinical implementation.
Thank you, Prof. Tai. I think it was good. I had a chance to meet up with Doreen. I think that's the direction that you're taking. Can I just ask you one question before we move on to Neil? Why is that the direction?
The strange thing about values is that we all have them, and in fact, when the lesson that I've learned is that when my values no longer match the values of the institution that I work with, it's time to go. It's that way because this is what I believe. It's also, but I find actually that in the medical community, we actually share those values, and in fact, many of us, as we begin to practice medicine and we get embedded into health systems, we actually find that it takes us away from the values. And I think that what happens then is that the tension between what is our natural values and what we're asked to do becomes so great that people leave. I actually think that this is the reason people leave a private practice. I don't think it's just money. So I think it's something that I carry with me everywhere I go. And it turns out that the entire team in Precise buys into it, and we're at a stage in our development. And maybe, Fiona, this is a natural progression, right? You championed this for years before I even started to think about this. But there is a sort of greater acceptance that this is the way forward, and in progressive societies, this is the way it needs to be. If we're genuinely going to reduce inequity in our society, you have to do things this way.
Thank you, Prof. Tai. So I think what's repeated and what's resounding is John mentioned training of stakeholders. We need to train and educate those who engage patients, and we will also then need to train and educate patients for patients to be engaged as well. So I think it's a whole collective effort. So Neil, over to you, being from coming from industry and leading patient advocacy for Pfizer. What are your thoughts on what we're discussing, and where do you see this heading, especially in the patient engagement, patient involvement front, at least for Singapore for a start? Yeah, and then I'll take us through to the next question on how we're going to get there and what we can do. Yeah.
Okay, thanks, Raj. So I think I can speak for Pfizer, but I think all of industry is committed to trying to empower patients to have more knowledge and understanding around the health systems where they're in, but also really own their journey as much as they can do within the dynamics of their health system. And clearly the region is very diverse in terms of patient populations and healthcare systems and structures. So we have to be cognizant of that. We also have to be respectful of the fact that patient groups are on a different journey. Not everyone wants to elevate beyond individual care for individual patients. Not everyone wants to move to a policy landscape or to engage in policy. So we really have to be respectful of that. I think as an industry, we're evolving as well. I think we were traditionally very focused on healthcare professionals as key customers, but more and more we're shifting to the end user and really trying to put the the patient at the center of what we do. Now, when we think about patient centricity, the way we think about it in Pfizer is very much listening and learning from patients. I think that's really important, not to presume what they want or need. So we've got to listen and learn. And then we've got to act on that, and we've got to act with accountability. So we cannot just pay lip service to needs or desires that, what the patient community are telling us. We actually need to respond to that. And I think as an industry, we are getting better at that. But different companies do this in different ways, and I think that evolution is happening. But it's like everything in life, Raj. It really does take multi-stakeholder collaboration to lift everyone. And I think industry remains committed to work with the patient community, to work with regulators, with policymakers and clinicians to actually try and lift the bar in totality. And it is a journey, and I'm sort of glad that starting with Singapore, and then moving beyond the borders of Singapore into other parts of the region. We know there's a lot of unmet need. We know there's a lot of work to be done, but I think industry is here as a partner to really work collaboratively to make progress.
Thanks, Neil. Can I ask you to identify the stakeholders? Hi, Neil.
Sorry, Raj. Just repeat.
Can I ask you to identify the stakeholders? Because it's nice to hear industry say that. And so I'd like you to sort of identify the stakeholders for us today.
Well, I think one of the first things that industry can do is actually work collaboratively within its own stakeholder boundary. I think one of the frustrations I have is that we don't have an industry association in the region. We don't do many multi-company collaborations, which we could and should do. We do it in other parts of the world. We just don't seem to do that much of it down here in this region. And I think that's a missed opportunity. So industry itself needs to lift its game and needs to work more collaboratively. When we think about stakeholders, I think broadly, large multinational companies have defined teams and silos internally. The market access team is talking to the regulators. The government affairs team is talking to governments. The medical teams are engaging with medical teams. So we know all the stakeholders, who they are. It's the multifaceted dimension of any healthcare system. It's around having the willingness to come together and have one consistent, coherent conversation. I think CORE has started a lot of that, and I think there's an opportunity to continue that. But when I think about industry, and I think about the potential that industry could have if we just aligned on some things and pulled that into the more very fragmented healthcare system, we could do so much more collectively through vehicles like CORE to actually benefit the patient populations, which we're all there to serve and support.
Thank you, Neil. I'm just going to come down to the gist of it. So I think what we did in the conference was to actually try and figure out what the three statements were. I think the first clearly looks at best practices in patient engagement, also to increase patient involvement in the development, regulation, and access to health products. Now, having said that, there are about 100 registered patient groups and probably another 100 patient support groups in Singapore. I think the tone for all of this work could be set if we can identify with the term patient support organization. Because I think industry likes to use the term PAG, which is patient advocacy group. So I think advocacy is a huge word. And the thing is, patients don't seem to be able to express their unmet needs or their journey, insights, or experience because they're always viewed as a group that need to advocate. But if they knew their journey in supporting another patient and the family, maybe things would be different because when they go see Fiona, they're able to tell you the story of 20 other patients and exactly what the journey is. So echo what I'm sharing now. What are your thoughts on this? On where does this need to go? Because I think before we start all of these conversations, patients need to know patients first, and patients need to care for patients before trying to get down into trying to advocate for so many other things. But I think health comes first, the life comes first, the journey is important, the insights are important.
Right. You're right, Raj. Yeah, in the beginning of the patient group, I feel like we need to get to know each other, practice with the deep listening for each other. basically we do the internal organization before we think about outside stakeholders. So, but it's not easy. It's quite challenging for the patient to get together at the first place without the healthcare provider to support it, especially for the chronic disease or rare diseases. In my experience, if the doctor initiatively introduce this patient group to the patient who come to their clinics, the patient organization will move faster instead of running by only the patients. To think about the patient and family, they not expect to come together. They just need a treatment properly. They need someone to explain about their condition, and they want to come back to their home and take care of themselves. So they're not gonna come to things about, okay, they have to fight for the treatment, better care, or some changing the policy at the first place. So at the beginning, so that's why when we run the patient organization without the doctors, also difficult to find the patient in other places to let them know that they have the patient group waiting for them. Because in Thailand, or I think in other low and middle income countries, the doctor, they don't have time to explain about how the patient will take care of themselves at home. So this part, the patient organization can play the role important in this part. So it's kind of both way that the doctor has to think to trust the patients and support to have the patient organization and use the patient organization as tools to support their clinic or their treatment. And also the patient group, they have to think about, so there's not just a passive. So they have to change their attitude that if they come together, they can come up with something in common needs or unmet need that they need, and their voice can be louder to go to the doctor or healthcare provider or even the policy maker, and things can change if they come together as a group. Individual patient cannot change anything, but as a group, anything is possible. And nowadays in Southeast Asia, I think they tend more and more that they support to have a patient group. They open opportunity to the patient can get together. In some country in this region, it's not quite the good ecosystem for the patient group, but majority of Southeast Asia country, they support to have a patient group as well.
Thank you, Ekawat. I'm going to take a question here from Shankar. I think his question is, how do we promote real patient centricity in the medical world? Prof. Tai? You're muted.
Okay. Okay. That's a tough one. I'll Shankar, I'll tell you in about 10 years how we did. But I think the way that we're doing it is beginning really, as we talked about this business about sort of paradigm skills and platforms. We have been working with leadership for a couple of years now, and really at least within our health system. And as I sent a couple of links out in the chat, many health systems and at the Ministry of Health level, we're beginning to sort of accept that we need to sort of, this is the way we would like to be treated, and when we deal with our clinician, our patients, we should do the same for our patients. I will make one comment, and that is that we did a study a number of years ago about where the greatest distress comes from in the lives of, the psychological distress comes from in the lives of our patients living with diabetes. And it turns out that the greatest source of distress is actually from their family members. The family members just feel that they should tell them what to do, and that they should know what to do, and that if they're not doing it, that they're being lazy, and that if you get diabetes, it's because you're ill-disciplined or something like that. I think it's important to realize that all this is an empirical sort of, it's a fundamental human behavior that sometimes we don't give enough autonomy to those people that we're dealing with. So, just simply involving patients is not going to be the key. I think we do need to train people right? And applies to both providers and patients as to how to sort of communicate effectively and in a patient-centered way. So we talk about patient-centered communication and not just patient-centered care, and I think that's really important. So you need to have the paradigm. You need to talk about it. You need to articulate it. People need to have the skills that in order to engage effectively. And then finally, you have to make sure that your systems are in place, so that, as I say, the way that we organize the care, the way we measure performance, how the way we provide incentives is all aligned to these values. And once there's discordance, it creates a huge amount of difficulty. And in fact, one of the things that we did when we began to pilot this within our clinical system is two things. So when you talk to patients, so this goes back to Taufik's question on the chat, right? That culturally, people told us, culturally, Asian patients don't want to participate in their decision making. They just want the doctor to tell them what to do. Now, that may actually be true, but the more we do this, the more we realize that it's not. And in fact, the moment the patients experience this, they know immediately something different is going on. And in fact, they do tend to like it. I think that's really, really important. But the other thing to sort of point out is that if a patient says, I don't want to decide, I want my doctor to make me a recommendation, that is not moving away from patient-centeredness. That is a patient-centered choice. And when we respond, then we will respond appropriately. So I think it's really important to recognize that I don't think, first of all, that it's a purely cultural thing. I think people are not used to speaking up because they haven't been given the opportunities, and given the opportunity, very often they do. But the choice to delegate the responsibility for decision to your healthcare provider is also intrinsically patient-centered, and we need to recognize that.
Thank you, Prof. I think well said. Not culturally defined, but giving them the opportunity. So Fiona, in your last couple of years in trying to engage with the patients, a couple of questions, into one. Are they ready? Do they know what they're talking about? Do you think they're open to come forward and share their insights, experience, and journey?
Some are and some aren't, and that is not unique to Singapore either. You'd expect that everywhere, and it comes back to echo what I was saying before, that many patients that we're identifying through the different patient support groups or patient organisations are there really just to network with people who are going through a similar experience, to share their stories, and to have that support network there. They're not interested in informing policy. They're not interested in lobbying the government or even finding out about which new treatments are potentially coming that they might want to have access to, because they might be well managed already on their existing treatments. So these type of conversations are not something that they're readily wanting to have. And for this reason, when we did our stakeholder mapping exercise a few years ago, which was needed because there was no actual centralized database in Singapore with all registered patient organisations. A lot of them are captured, but then there are a whole lot of splinter groups that we often find, and there was a lot of word of mouth needed to be able to identify the ones that we've found so far. And even once you've identified them, we spent a long time having to speak to each one of them to work out whether or not they would be interested in helping to inform policy, or whether or not they don't have capacity or it's not of interest to their members. So from that, we have distilled it down to a group of about 100 patient organisations that are interested in, it's a little bit more than that, contributing to our work, either broad policy work or condition-specific work. And we have been engaging some of them so far. Now, I know there is a question in the chat about how we actually reach these patients, and there's an example of a type 1 diabetes patient who has not been asked to contribute yet. And from the work that I'm doing at the moment, we engage based on conditions. So if ACE is currently evaluating new treatments for type 1 diabetes, we would then contact the relevant patient organisations and ask them to survey their members to put a submission together that could help inform the HTA. Now, over the last 12 months, we haven't done an evaluation of a type 1 diabetes treatment. So for that reason, that's why we wouldn't have engaged that patient. But in saying that, going forward, a lot of engagement has to go beyond condition-specific work. There's a lot of experiential knowledge that the patients have when they're navigating through the healthcare system. They have different preferences, and even in clinical design, trial design, all the way through to market access, there are different aspects of the life cycle of treatments that patients can contribute to, and we need to really find a way of harnessing their knowledge, because that real world experience is going to make all the final decisions on access relevant to the end users. So we've started at just a really small type of engagement strategy by going condition specific about specific technologies that we're evaluating, but we really need to collaborate and go broader than that. There's just so much more information that patients can share.
Thank you, Fiona. So
Raj,
I'm going to bring, yes,
Raj, it's something that can speed up the patient organization to grow up if we can find the pain point. If they don't have the kind of urgent situation or no, it's so difficult for them to find. They have a target or they have a purpose to be together. If they have some problem and they find some unmet need in their group and no one can help, and that the patient group have something that they think they can distribute to for their own benefits, I think that can speed up.
Yeah, so it's peer-to-peer, it's support within patients. I think those are very important channels, right? So, I mean, we spoke about all of this at the last conference. So I'm just going to bring us back to the conference now and when we move forward. I think at the conference, there were a couple of things in the 3 statements, and we thought about it with my colleagues at CORE and also Kate on what we're going to do next. And I think we had a conversation amongst us, the panelists as well. How do we move forward? So we're going to use Singapore as a test bed or as a pilot. And also we've got Ekawat, who was at the conference, and he's from Thailand. He's worked with CORE for a period of time. That how do we move forward? What is it that we need to do? And so in that series of engagements, what we realized with both industry partners, the other stakeholders as well, is I think it's been a long series of training patient groups previously. So what is it that we're going to do next? I think what we want to do is to prepare each patient to be equipped enough to share their own journey, insights, and experience. That would help us as a whole community and also giving them empowerment and confidence. So I think when we first discussed that, actually I didn't get in touch with Precise yet, and then we got a call to say, hey, they'd like to do the same thing as well. And then when we're talking to Fiona, and Fiona said, hey, look, we're coming out with material. And CORE was saying, and then so when we discussed this at CORE, why don't we actually all work towards the same outcomes? Because what we're trying to do is to increase the patient involvement and the quality of the engagement as well. And that's not just for the patient, but also for the stakeholders who are involved. And I think what we wanted to do is to look at the kind of stakeholders that we have. Where in Singapore, you've got the still to be, registered NAPOS, which is the National Alliance of Patient Organizations. You've got SAPI, but I think what we need to do is to see where we're heading. And I think there was one spot that really hit it sweet when we looked at all countries, whether in Malaysia it's MATA, Singapore is ACE, and then you've got HTA. HTA seems to be a big topic. So can we use that as a starting point to actually train patients? Because in every country, it has become a necessity to equip them with that skill and the proper narrative so that they can articulate the patient's pain points, the journey, and the insights. So Neil, can I just get this question to you? How do you think we can start as a collective group? I mean, we've got multi-stakeholders, and then you're looking through a couple of countries. Any thoughts? Because I think why I'm asking you is, having worked with industry for the last couple of years, what I've also realized is they over-prepare their patient. And sometimes agencies like Fiona's just don't want them to be over-prepared because all they want to hear is the patient's perspective. And then, so what is it that we're preparing them for? Because all we want to know is the patient insight. We don't want to know about economics or the clinical part of, HTA. So I've seen that in Malaysia and Thailand too. So maybe your perspective on that.
Yeah, I think, look, it's an interesting question, Raj, because it's not easy to unpack. I don't think there's a simple answer because we would have found it by now in other HTA systems around the world. the patient voice is really important, but it's the question of how is it captured, how is it evaluated, how is it weighted, and how is it fed back into the decisions that are made. I think industry has done a lot of, or supported a lot of efforts, either as individual companies or through third parties, to try and educate patients regarding HTA and processes. But it's like many things in life, you have to go through it to actually come out the other side and understand what adds value, what's really gonna make a difference. I think the first thing in terms of the multi-stakeholder approach is just getting everybody in the room to talk around the gaps and aligning on where the gaps are, and then finding a vehicle to actually do that education and do that training. And clearly, HTA systems that vary around the world. Singapore, I think, has got a fantastic foundation in terms of the openness from all stakeholders to want to engage and to want to really embrace the patient voice. So the opportunity is to align in Singapore to really demonstrate the value of that lived experience from the patient, and then actually push that out to other HTA organizations, either in the region or more globally. You know, we know HTA has been around in many different parts of Europe for a long time, but people would also criticize that there's no one perfect system. I think Singapore is starting at the point where it can embrace from the ground up the patient voice from the very beginning and bring that in all the way through, and make sure that the value that the lived experience brings into the process is realized throughout the process and beyond the process. Some of the criticisms we see in Australia, for example, is the lack of feedback mechanism from when consumers put into the process. So it's just important, if you're going to be respectful enough to ask for commentary and input, you need to be respectful enough to close the loop around what does that mean and what's the weighting of that. So I think getting the stakeholders in the room, being really defined around what the problem is, and then group solve what the solution could and should be.
Thank you, Neil. Echo, so in Thailand, you've got high-tech. Why do you think this has become a priority in the region?
I think high-tech in Thailand try to get the patient involved in this level, but it's quite challenging for the patient group to join in this level. They try to have the workshop only for the patients, use easy words to make a patient understand, and they try to make the patient expectations. They want to know the patient expectation and government expectations to be fit and be parallel, and they understand each other. So just avoid to missing understand for something. But it's kind of slow step. First, you have to strengthening the patient organizations, find the right person in the patient group, because it's possible to make all the patient organization, the members, to understand about HTA, but at least we have one or two patient representatives to understand in this process. They can share their own journeys, their unmet needs, or something that they want to contribute to the HTA committees. If we want to come up with something to support patient organizations, it's going to be the short term and the long term. For the short term, maybe with the soft skill, how to hold a patient organization, which is not easy because we are volunteers. Some organization is no full-time work in the organization. How we hold this group together? The activity is, if they overwhelming for this group, they will run away from the group. Okay, so this is kind of balance between the soft skill and the hard skill. With the hard skill, we have to select the right person in the group and train them, push them into the upper level. So I think it's very, very artistic grooming exercise to do for the patient organizations. But I think we can have more volunteers, healthcare professionals, family members to be part of this patient organization, because some chronic disease or rare diseases, only the patient cannot run something like this.
Understand. Yeah. So I think, echo what you have got a very sweet suggestion, because if you look at patient groups around the world, the more developed and professional patient groups are run by a mixed bag of volunteers, not just patients alone. Maybe the balance is about 80-20, 70-30. I think it's for effective governance as well. So it's a very, very, very good point. I think from what you're telling us, I think it's quite clear that what we need to do is to make sure that we can train the patient group and provide them with the capability, the capacity also to actually come up to this and to be involved. So Fiona, just coming back to you again, to make this a success for Singapore, I hope that you don't feel over obliged because it's HTA, but we think this is a necessity. Having sat through all of the conferences from 2019 to date, 2022, year end of 2022, I realized that it's a topic that's always left unanswered. HTA. We just keep telling them, people keep talking about it, but no one's doing anything about it. And when we spoke about this, and even in our conversation, we said that, look, we need to do something about it. And CORE said that, look, let's coordinate it. Let's work with the relevant agencies to make sure that we're on the same page, so that we can move forward in a national, at a national level, and it becomes a national priority for us. Yeah.
That's absolutely right. And I think, ACEs, our patient involvement is really around our work. So at the moment it's HTA, we do have other work streams, and so it will expand over time in terms of clinical guideline development and other aspects. But for now, we're focusing on HTA. Therefore, all of our training requirements that we're providing to patients or starting to talk about giving to patients is around that. And that's not the whole picture. We've got all different stakeholders here, and we've been talking about looking at training throughout the entire life cycle and the patient experience in the healthcare system as well. And so it made sense that we collaborate together and almost create different modules that address different questions that different patients or patient organizations have, because not everyone is going to want to know about the HTA process. A lot of them might just have some questions about their condition so that they can make a more informed decision about their treatment options, or how to understand how to navigate the healthcare system or the healthcare financing framework in Singapore, for example. They're all different questions that they have, and we need to come up with a comprehensive package which can be tailored to different modules so that it meets the bespoke needs of each different patient organisation and their members based on where they are in their patient advocacy journey. And hopefully over time, as more information is provided on some kind of platform, they will upskill, they'll become more interested in learning more as well, and potentially then want to contribute more to different processes that they might have been reluctant to contribute to before. In saying that, though, I think we have to be mindful as well about empowering the patients too much on their own. We were talking about multi-stakeholder involvement before, and something that really interested me when we first started doing this work with the patients was the pushback that we got from clinicians. So we were talking to them about maybe giving the patients a couple of questions as a bit of a toolkit that they could take along to their consultations to ask their clinicians about their treatment options or about their condition. And a lot of the clinicians we spoke to about this pushed back and said, this is going to increase the consultation time. The patients shouldn't be questioning my decision. I'm the one with the medical degree. And they got really defensive, actually. And so it is a fine balance, because it is a partnership and clinicians are an integral stakeholder in this healthcare ecosystem. But we're talking a lot about patient centricity in the system and also shared decision making. But everybody needs to be on board for this to work. Doesn't matter how much training you give patients or how much they feel empowered to ask these questions. If the clinicians and other policymakers and other stakeholders are not willing to engage, then it's a waste of time for everybody. And, we've already got scarce resources and capacity. So we need to really tailor the offerings to meet the critical needs that patients have at this point in time, and then build it up over time as their needs change.
Thank you, Fiona. So I think we need to start right with the first interaction. I think Prof. Tai has mentioned that, and Fiona, actually, you mentioned that as well. That's one. Two, we need to work collectively And I think in all the discussions that we had just before the meeting, CORE is going to, take on this role to try and coordinate the efforts, but along the same strain as the developing agencies in Singapore, that will mean ACE, Fiona, to build on the nationalistic need rather than to work on separate work streams. So I think what we've defined clearly is, we're going to look at HTA, we're going to be committed to look at HTA and other streams as well for the next 18 months or so. And, I think we're open to have partners come and work alongside with us. We will also continue to partner with other organizations, agencies to actually move this forward for Singapore. My next question now, Prof. Tai, is I think Jay Chandran has asked, how can we use technology to encourage and promote patient engagement? Are there examples already? So I think with ECOWAT, we've seen on the hemophilia front, we've seen engagement during COVID from the diabetes front, where patients lock in, their experience on a daily basis. There's an ethnography, app that actually captures patient input as well. How can it be part of the work that we do for engagement in Singapore, Prof. Tai?
I think the question was very specific about how AI would be used for this process, and I have to say, I think that there's a lot of potential for AI, but it's not clear to me how we're going to use it. I think at some level AI has been used in customer relationship management for many years in many different industries, and why we shouldn't start to see its incorporation as an adjunct to relieve some of the time pressures and the resource pressures on our providers is I do think that it's something that needs to be done. But I think that there are concerns that sometimes the things that come together are wrong, or there may be regulatory issues, and this may be one of those things where involving patients and asking them what they think about this, I think, will be incredibly important. But I think that's different from using technology as a channel and a means of communication, right? I think that Fiona's point is very, very well taken. In fact, when we've done this in our own organization, we do get a lot of pushback from practitioners, primarily because of the time. Now, and this is why I've sort of taken the effort to sort of belabor this idea that the whole system needs to be engineered in a way that is consistent with your values, right? You can't say one thing and do another. So it comes down to then, if we are going to move forward, there was a question in the chat about Healthier SG. If we are going to move forward with empanelment, then how are we going to create these panels? So this is a group of patients that one provider is responsible for. How are we going to create these panels at an optimal size and case complexity that will allow the provider to deliver care that is consistent with the stated values? And then how do we have a system for sort of load balancing? We haven't had these conversations. It's a very difficult conversation to have in a system that has been built primarily around maximizing productivity, and measuring productivity as almost like a turnover, right? How many patient visits did you see, as opposed to how much value did you deliver to this group of patients that you're accountable for? I think it requires sort of lots and lots of shifts in the system, but if we don't take it on, then we'll never move any closer.
Thank you. So I'm just going to reply to Timothy, live now. I think in light of Healthy SG, I was wondering if Kate has worked with MOH to shape future primary care from a patient perspective in Singapore. So Timothy, yes, I'm involved in Healthy SG as well, but the thing is, it's still early in the day. It's going to probably be launched sometime in July. We're looking at options, and we'll get back to you, because at this point of time, I think the details are being worked out. So it's really too early for us to actually discuss. And I think Irene's question here in the Singaporean context, how can the different stakeholders support the training of patient organizations to make it a success and equip patients with the right skills? So I think this is a good question for Neil as well. But before that, I just wanted to just lay this question with the fact that patient groups are at 3 different stages: the beginners, your intermediate, and your advanced groups. I think with CORE, we have that in mind. And what we're going to do is to prepare, material that will be suitable to all of them. But I think it's a very good question on how the stakeholders can come together. I think one of the earlier points I raised is, look, we need to work collectively, and we need to make sure we identify what the priority is. And so any thoughts on this, Neil? How can we work together, the stakeholders, who they are? Of course, being industry is one of the key partners that we have as well.
Yeah, look, I think industry is committed to partnership. I think industry has proved, either individually as individual companies or engaging and supporting the work of independent third parties. The two things I think about when I think about training and capacity building is, from an industry perspective, is much of it, if not all of it, should not be industry led. We discover, manufacture medicines. Training and capacity building is not really what we do when we think about the patient and the patient journey, from my perspective, and that's my quite strong view around the fact that we need to be sensitive to the fact that the best models are the peer-to-peer models, patient organizations partnering with other patient organizations to build capacity. So that's a model that I'm a very strong component of, or independent third parties, not just industry-led work. The other piece that really comes to mind is the whole challenge around health literacy, because health literacy means so much to so many different stakeholders in so many different countries and so many different healthcare systems. And I don't think it's as simple as just saying around patient organizations, there's the new or the young groups, there's the middle tier, and then there's the more advanced tier. It's really around how do we look beyond the patient organizations and look at the patient community more broadly. We know that there's a significant proportion of patients that are not affiliated to patient organizations, that are going on their own patient journey. So how do we reach and engage with those individuals on their journey to help support them, how they navigate the system, how they plug into HTA systems? So it's a really big challenge, Raj, and I don't think there's a simple answer, but we have to work collectively and be committed, not just for 5 minutes or 5 months. It's really a 5-year exercise here. It's a long journey. We need to be prepared to be involved and roll our sleeves up over many, many years. Now, sometimes that's a challenge for industry, given our funding cycles is often annual, but we need to sort of back a winner here, and we need to continue to invest year on year and grow that investment to support the patients and the patient communities. You're on mute, Raj.
The 2 words I was looking forward from you were collective, and of course the cycle of the funding, and so that the partnership doesn't just fall out after 12 months. Ekawa's smiling as well, because that was the answer that we're looking for. Industry needs to support with more than just 12 months, because
a long-term support.
Yeah, and so I think that would help to build this whole collective effort and to keep it running for a while longer as well. I just want to go back to Irene's question. How can the different stakeholders support the training of patient organizations to make it a success? So Irene, it's not all about just medical advocacy, but I think in a patient group, there are many, many different tiers and support systems that would involve the governance, because patient groups in Singapore will need to adhere to the governance that's required here and what they're supposed to do, how to manage the board. The next would be also to then think about the program management as well. And I think if we can actually move forward, the next would be building the membership of patients, because I think these are some of the areas that we need to look at more than just medical advocacy as well. So I think I'm going to come back to the point of now, how can we work together? So I think Fiona, Neil, Ekawat, Prof. Tai, can we just have a discussion on who we think might be the immediate partners in Singapore that we can look forward to working with, at least for a start? So if CORE is going to sort of organize this, and I'm going to pull everyone together. I think what we've done is to make sure that we can align with ACE and what they're trying to do. Prof. Tai, any thoughts on it first?
I mean, not all patient involvement needs to be around regulation. I mean, I'm relatively new to this group, so I probably shouldn't say too much, but because I don't know the landscape as well as I could. But I would imagine that probably there are different organizations that you would need to get or want to get involved with, depending on what we're trying to achieve. I can tell you that, for example, that if the question is around healthcare SG, then we are gradually, hopefully over the next 6 to 12 months, going to put together a program that will ask how can we make every health plan in healthcare SG a patient-centered one. And there will be efforts around that, and they're the stakeholders. You asked Neil this question, and my definition of a stakeholder is anybody who can affect or is affected by whatever you do, right? And there are going to be policymakers, there are going to be the providers themselves. Somebody said to me the other day, the doctors are often the victim in all of this, and I think that's really what Fiona is talking about. And we need to sort of think a little bit about how we impact on their lives, and also and patients become a key part of that. So I think for healthcare SG, there are these things that will happen over the next maybe 6 to 12 months, and we should expand this conversation. If there is a desire for a conversation around how do we deal with inherited diseases, then come and speak to Precise, and that will come in through the Chief Medical Officer's office.
Thank you. Fiona, your thoughts?
I agree with Prof. Tai. I think he summed it up nicely, but I just wanted to highlight when we're working with patients, I think it's important that we have almost a tiered approach and identify patient leaders. So those within organizations or within our community who are very strong advocates already, who are quite well versed in the healthcare system and have a lot of experiential knowledge from their own personal experience, but also from the members or other people that they engage with, so that they can champion the voice of the people that they represent or the diseases that they represent if we are lacking other members or patients who are unable to do so at this point. And in saying that as well, we need to make sure that a broad range of patients and conditions are represented as well. Chronic conditions, very common conditions, we can often readily find patients because there are quite a few of them, in Singapore, but the rare voice for those patients with rare diseases is equally important. They have very, very different needs to other patients with chronic or common conditions. And so if you are talking about a collective approach and developing some kind of training that's almost like a one-size-fits-all that can be broken down into modules that are relevant for all patients, we need to get all of those different perspectives, make sure that it's representative of all the different patient types in Singapore. ACE will obviously be a partner in this on the HTA side, but I'd really like to start seeing other aspects of ministry, and I'm not committing any of my colleagues in other divisions yet because I'm not allowed to do that, but we definitely need to expand it and go beyond just HTA and look at other areas of policy, financing, and all sorts of other key areas. People have mentioned healthy SG, but there's many other policies that exist in Singapore where we can make sure that people are well versed and able to contribute to that policy development as well, so that it is legitimate and can be implemented much easier downstream because it's had that buy-in from all the stakeholders who are likely to be impacted by that policy.
Thank you, Fiona. Echo, what do you think about the approach that we're taking for Singapore? You've worked in Malaysia, Thailand, Philippines. How do you think this will pan out?
Okay, I think so. Basically, for the patient organization, in Thailand we would like to see individual diseases as patient group. Even you have just a small group, you have capacity to meet annually. Okay, this is the first thing. So maybe you have a small budget for each patient group that allow them to meet. And now we have technology, so we can meet on Zoom and anything. But just be aware that the technology can be create a big gap also. If we just focus the technology, we leave someone behind, especially in the low middle income countries, because I think less than half of the patient can access to this kind of technology. So we have to do maybe the hybrid one. But at least we would like to see every rare disease or chronic diseases have the patient group. And then where we have, I think the good way to do the capacity building, capacity development. I just got back from Malaysia. They have a capacity development for the hemophilia group. That helps a lot to know where we are and where we're gonna go with and our future plan. So it just can do this every year or every 2 years to just see how our organization moving. That use the budget also. So I think if we have a long-term partner with industry or someone can provide the budget that patient can run this kind of activity yearly, that will be benefit for them and adhesive them together with a project. Without the activities, sometimes they just tear them apart. They just get back to work on their own life. So they just see this is not benefit to them. So we have to find also the patient champion for each disease, bring them together, have like a leadership program for them, and let them get back to their own organization and build up their own community. I try to develop the leadership program for hemophilia also because I'm not going to be able to hold this group forever. So we need to have a newcomer to replace my situation too. So this kind of thing like a circle activity.
Thank you, Ekawat. So I think what Ekawat's mentioned is the typical issues that every patient organization would face, the succession, training, identifying the leaders, but that will also then translate into us and the work that we want to do to identify key patient leaders who are able to articulate these narratives effectively and, put it out there in the public for policy to HTA and many other fronts as well. Neil, any thoughts on the discussions we've been having?
No, I think from an industry perspective, again, I think it's different companies will make their own decisions around where they support. But I think it's really important that everyone remains open-minded and committed in terms of thinking about multi-year sort of challenge ahead of us. And I really do want to echo sort of Fiona's comments around that broad representation from all patient populations, not just the more common patient populations, because as science, technology, and treatments are moving down more and more into those niche and more defined areas, which is great from a scientific perspective, the patient voice is not always there for those patients. I'm a father of a child with a rare metabolic condition, and I can tell you it's really hard to find an active patient voice for where my daughter's at. And so when you go into thinking about how you want to articulate that patient voice, it's really important that that spread is there. Just as we think about geographical spread, we talk about socioeconomic spread, we want to be thinking about broad range of patient voice from all disease areas.
Thank you, Neil. Prof. Tai?
I'm not sure, Raj, that I have a specific solution. I mean, what I value, and I think I said this in the chat too, is that seminars like this bring us together, and if we do share a common vision, and Neil, your vision of how we might even work with pharma is a good one, and I think it reflects your own personal experience, and I think it's important that we recognize that each of us, our values are often shaped by our personal experiences, and I think that's great. I think what we need to do is to sort of work on this together.
Thank you. I think that's a good end point, because I think that's what CORE is trying to do, bringing the partners together so that we can prepare the patients for better engagement and involvement as well. So I think we've identified a few. I think for those other partners who want to continue to work and the journey with us, come forward, let's speak. We are going to have a couple more dialogues with industry and other stakeholders as well to see how we can build this together, because what we want to do is to build a collective platform, a platform that we can achieve together as well, and to actually have the same outcomes. We have identified what we want to do at a national level, but I think you can share your thoughts with us as well, and we're open to it. So with that, I think we end early and not just on the dot. I'd like to thank Fiona, Prof. Tai, Neil, and Ekawat for joining us today. And for all of you who have joined us today, the close to 168 people who've listened in to us, share your thoughts. We will continue to dialogue, but I think we're taking the first step together. And I think we've given you an indication on how we're going to work together and how you can be part of it as well. So thank you very much.
Thank you, Raj. Thank you, everybody.
Thanks, Raj. Thank you.
Thank you.